At some stage I thought that individuals, including me, were looking at the issue of equalities far away. It was associated with not us. And getting interested in the topic, I realized there's something very, very close. This is Europe, even closer. This is, amongst other countries, Germany. And very close, it is the very diseases that I'm so much interested in. If you look around in your own vicinities, there are severe inequalities. There are factors on that. And there's literature about it. There are people that thought about this a lot longer than I did, or a lot longer than our organization did. And I thought something needs to be done. Something needs to be publicized. It needs to be in the agenda. And people need to be made aware of it as a start and to see where we're going. If you look at the Baltic republics that are democratic nations, part of the European community, and if you look at some, let's say, marker diseases, outcomes in cystic fibrosis, for example, you have to realize that the good news is these republics have a healthcare plan. They're extremely active in that, which is the good news. The bad news is still that if you look at outcomes, the survival of a child born with cystic fibrosis in Tallinn today, compared to a child born with the same genetic defect in Amsterdam today, the life expectancy of these children would be significantly different, and not just by single years, we're talking decades. We're talking the difference between something like around 15 years versus something around 40 years. That's the sort of magnitude we're talking about. Obviously, there is the consensus that there is a European gradient east-west, to some extent north-south. But what is particularly interesting, this even in very, very small areas and cohorts, this works. So if you look at the Jubilee line in London, and if you travel from, let's say, Westminster, and you travel to the east, about every 2 tube stops, you lose 1 year life expectancy. Now, what does it tell you? It tells you you have to look at your own remit and your own environment to actually find out where it is. And you will realize that in every community, I would, as a hypothesis, wherever you go, not northeast, it could be in every Western society, in every Eastern society, in every Northern society, you find these areas when work really needs to be done.
Health has been improving drastically in the European region. However, we see an increasing gap, namely health inequalities within one and the same country, within one and the same city, and also between countries, for example, between the western part and the eastern part of the region. We have now been conducting a region-wide study with Sir Michael Marmot and the team on the social health inequalities in the region, that there is a difference in life expectancy between countries up to 16 years, and even between men and women, a difference of 4 to 7 years.
For cancer and for heart disease, there's a social gradient. So if you are less well off, you're more likely to have more cancer and more cardiac disease, more ischemic heart disease. There is also a similar gradient for respiratory disease. The UK have done an awful lot of work on this, and they've shown that chronic obstructive airways disease, asthma, childhood infectious respiratory diseases all follow a social gradient.
So if you map countries of the world, you will find that the poorest countries have the highest rate of TB and the richest countries have the lowest rate. And it's not a complete, perfect linear relationship, but it's almost like that the richer a country becomes, the lower the risk of TB is in that country. People start moving from areas where you have the worst problem to the countries or the settings or the cities where you have a little bit better chances of getting a job and finding yourself in a better economic situation. So of course, as a communicable disease, that is an additional challenge that could arise in times of economic recession.
We see equally a gradient in what are called disability adjusted life years, so that people in poorer sections of society, not only do they die younger, but during their life they spend longer with periods of ill health and disability.
Health is in many ways socially determined. That is, there are a number of factors in our everyday life which impact on our health. Those factors impact from the earliest years, indeed from the prenatal period when we're in the womb, and they continue and they accumulate across our lives.
Lung function is determined early in life. So whenever children are born into poor households, they are more likely, first of all, to be born prematurely, and this can affect their lung function because their lungs will not be properly developed at the time of birth. Second of all, they're more likely to be born into a household where there's cigarette smoking or a lot of particulate matter. We know that individuals who are born into richer families have less of these risk factors and therefore at a later stage in life have less likelihood to go on to develop lung disease.
There are two aspects of unemployment which affect health. The first is the uncertainty that people experience when their jobs are threatened. The second is if they're unable to get a job again, spend a long period of unemployment. And there are many things that governments can do to ameliorate those factors.
What we see with healthcare is that there's substantial variation. So although the wider determinants of health are the most important for health inequalities, we know that healthcare also contributes to health inequalities because there's a lot of variation in what doctors and nurses do. So for example, with chronic obstructive pulmonary disease in England, we've found that there's something like a 4-fold variation in admission rates, emergency admission rates for COPD. So that means for me as a patient with COPD, I'm 4 times more likely to be admitted with my COPD if I live in one area than if I live in another area. And the same applies to mortality. We see 2-fold variation in mortality. So in other words, these important outcomes for patients depend not only on the condition or the severity of the condition, but they depend importantly where that person lives and which doctors and nurses are providing the health care.
There's very good evidence that nations that have developed a specific health care program that would have the ability, the willingness, the political willingness to do that you can actually change outcome. One of the prime examples is Finland. Finland was a country that had in European context, a normal, if you want, prevalence of asthma and obstructive lung disease. Now, Finland has been doing a lot of interventions, educational, change in healthcare system to actually meet and cater for the need of asthmatic individuals. Now, if you look at the outcomes, Finland is now one of the leading countries in terms of, good outcomes in asthma. So politics work, interventions work. Asthma in Finland is one of the prime examples that, it's almost a showcase, that if you understand something right, that is 20 years ago almost, you translate this not only politically, but also in a medical society, you communicate this, you understand the modulating factors, you can do something about it.
My fear in conditions like asthma is that there will be an increase in asthma symptoms and even asthma deaths. The Finnish experience, where they put in a very, very focused program of asthma prevention, resulted in great improvements in asthma morbidity, hospital admissions, asthma deaths. That's the sort of program that I would be really worried would be vulnerable and would be cut, and you could make short-term savings. You could say, well, we'll fire 3, 4, 5 or however many people, and then later on you see the mortality start to rise, the morbidity start to rise, all the good work being undone.
Investment in health is more crucial as ever in the austerity times. In fact, health has been longly seen as a cost driver, as an expenditure. But we have gathered a lot of evidence that health, in fact, is a very important driver to the economy. Better health means better wealth.
We can see from previous crises, in different times and different contexts, but still we know that crisis, an economic crisis, has an impact on health inequalities because the most susceptible to the financial crisis are the worst off and the most vulnerable groups.
In the case of respiratory medicines, it's even more worrying than for some other areas, because you have asthmatic patients that will not take their sprays. They may show up in the emergency room. So everyone with any understanding of how this works will realize that the saving now on the medicines is going to hurt you down the line, because it's going to be more costly, plus that people will suffer.
I work in a fairly large hospital. We have 740 inpatient beds, of which more than 400 are pulmonary medicine and about 50 are thoracic surgery. What really worries us is the fact that patients may come in and we may not have the proper medication, or we may not be able to diagnose them properly because something is missing. Patients were delayed in their diagnosis by 15 days or 20 days because we did not have the equipment to perform the biopsy. We cannot plan long term because we don't know what will be available funding-wise for the hospital, and we need to be able to have a strategy which we're not able to have at the moment. And this is also very frustrating. So it has changed the way we think about treatment and what we prescribe. It's not just the hospital, it's the pharmaceutical industry. They're getting very delayed payments, so they cannot import the drugs, or they cannot import materials such as biopsy, forceps biopsy, or brushes for bronchoscopies. So there are shortages in everything that we use on a daily basis in the hospital. If we are not able to provide the best care for our patients, then that's really a very bad thing. And it doesn't necessarily have to be done with the most expensive medication or the most expensive equipment, but it has to be done at a standard of care that is enough to allow the patient to have the best of his situation, the best of his health problem.
Well, it all started in 2008 when our Prime Minister came on TV and said, "God bless Iceland." And that's a pretty drastic statement. We knew things would change, and they did. Patients in Iceland with asthma, we find, were very well controlled. We have relatively mild disease, we have few hospital admissions because of asthma, and we were doing pretty well, actually, before the cuts, which were on 1st of January 2010. What they decided to do then was to take away all combination medications, so inhaled corticosteroids and LABA in combination. What basically we looked at in this study was trying to look at whether this decrease in the use of combination medications, and they decreased by about 77%, after the 1st of January, had an impact on asthma control. And what we found was that, alarmingly, almost 30% of asthma patients were on no medications at all of any kind. So almost 30% on no medication. Of the COPD patient, approximately 15% were not on any medication, and that's very worrisome. What we also found that in the group that was well controlled, had well-controlled asthma or COPD, those patients seemed to be doing worse, because what we found was a doubling of the short-acting beta agonist use and almost doubling of the oral corticosteroid bursts they were receiving. After we have these results now, and we see that the drug savings are minimal, and we're not even taking into account increased hospital visits, increased visits to healthcare, or increased use of other medications, or the anxiety or work loss that patients experienced. The savings are less than 10%. The good news is that the government has now decided that as of June of 2013, we will again be able to prescribe the medications that we think are most appropriate for the patients.
People will buy acute relieving medications such as bronchodilators, but they may not spend their money on the preventive inhalers that stops the problem in the first place. So cost of medication undoubtedly impacts on people's utilisation of it. And as money is squeezed and salaries fall, this was likely to get worse, in my view.
The thing that frustrates me a lot is that there is no real debate on the pharmaceutical side of it. There's a huge divide, it seems, between the research community and the policy community that study these determinants of health and the private sector. We have, from the pharma side, maybe not invited ourselves always to these forums where this is discussed, because it will be painful. But I think the industry is absolutely ready, and we show that in a number of countries around the world, that we're ready to engage in real access programs. You know, how do we make sure that people get the medicines we spend so much time and money on developing?
We have to advise policymakers where relatively easy steps can be taken to change outcomes. The UN, together with the WHO, has developed some scheme of doing this. They looked for, if you want, best buys. They would say, are there some areas where there is a best buy scenario within, meaning with the input that you have to give, what do you get out of this? One of the prime examples is asthma. It's a best buy because it is something that is medication that is affordable, it is relatively easy sort of administered, there is a broad consensus that you should be doing this, and if you would actually improve and increase that level, what you get from this is a lot on a population basis and outcome. So asthma is one of those examples where one would be very concerned if austerity measures would restrict any of those measures and or these interventions.
What we need to do is to really focus on the critical early pregnancy and early years of life. That's where, if we cut corners, that's where we will pay the price for decades. We need to focus on making sure that pregnant women have optimal care and the optimal environment, that our infants and preschool children are in the optimal environment. That's when we need to focus, but the trouble with that is you see the fruits of it in years to come. In short-term politics, you don't see any fruit immediately.
In these times, it's really easy and tempting to make cuts that can give immediate and short-term money available, but if we start removing social protection, if we start lowering unemployment benefits or also childcare or long-term care, especially for the vulnerable groups, this is really going to have a great impact on, and not necessarily just on the long term, and this is really going to be counterproductive.
You can change things, you can change outcomes, you can change diseases, respiratory diseases, but there needs to be a baseline agreement on sort of funding. And there's one other big word that we need to use there is solidarity. We have to understand in the European system and all the discussions about who's helping whom and sort of, the banking system, but for healthcare provisions, it is an area that requires solidarity as well.
I think it behoves us as health professionals to get our houses in order, to take on the challenge of reducing variation that cannot be justified. If all the primary care organisations performed as well as the top 25%, that would save something like 8,000 lives a year from COPD, which is an enormous impact that healthcare could have on such an important outcome.
We must never lose sight of our social safety nets, and these are at risk in times of austerity in Europe. Those will ensure that we keep as few people in poverty as possible, and that will reduce the number of children who are born prematurely. Likewise, cigarette smoking. This is an area which is not amenable to individual action alone. So for the two major factors I believe that influence lung function, they are both socially determined and they can only be overcome through government action.
The WHO European Health Policy Health 2020 is an action-oriented policy framework targeted at the ministers of health, but very important at all ministers within the government. And it has 4 priority areas to tackle the health inequalities. The first priority is what we call to tackle a lifelong approach, meaning that we have to start, in fact, even before birth, with health, prenatal, with the pregnant women, and keeping this healthy lifestyle approach throughout. The second priority is strengthening health systems with the persons and the patients at the center. The third priority is to tackle communicable and non-communicable diseases. And the fourth priority is in fact to empower the communities. We educate the people themselves to take care of their, let's say, lifestyles on disease prevention and health promotion.
I think the experience from across the world in systems that are performing well is that an empowered patient is absolutely key. To have these patients feel that they are responsible themselves for managing their disease. When you give them the right tools, the right ICT tools or other tools to actually make the scheduling of the appointments, they get their values on the screen and so on. That's absolutely critical, and this is where we have still a lot of work to do in Europe.
Well, health professionals are actually in a very good position to advocate for tackling the social determinants of health and for closing the gap and reducing or leveling up the gradient in health. They're in contact with the patients, and they are in a position in which they can empower communities and individuals to take control over their health and their health behavior.
Education in terms of respiratory diseases like asthma and cystic fibrosis is extremely important. At the Royal Brompton Hospital we have specialist respiratory nurses spending time with the families, with the children, explaining why we're doing the treatments, making sure the treatments, say, with medication delivery devices are done correctly. But of course there's no point in having an asthma medication if it's not being inhaled properly. So they spend a lot of time doing that. And again, that's a relatively recent development, and the worry, of course, in terms of times of economic hardship, when you're looking to cut, these are the posts that go. You cut the respiratory specialist nurses because nobody's going to die immediately because the respiratory nurses are fired. You see the effects rather later on, and people don't put two and two together.
It is not only about money. That's what people have understood. It is your society, it's your educational level that drives benefits for your population. So if you have to distribute money, you have to put money in the healthcare system, yes. But if you should forget to educate your children, you have a major impact on health. Not only on education, but on health. So social security drives health outcomes. And that means that the ministries of health and the ministries of education and the ministries of technology have to come up with one budget that is not fighting about the biggest share, but they have to understand if you educate, that put money in your educational portfolio, you will benefit on healthcare systems.
Better health means better wealth. And that is crucial also to pass this message to the other ministries in the government, because what we say in WHO and the member states is that every minister is a health minister. There has to be a health component in all the public health policies.
People can go through rough times if they know that things will get better, and they will get better long term and with a good plan for the next 10, 20 years. If we're going through all this for more of that in the future, then that's difficult.
So this is something that is gaining momentum, and I believe with the strength and the political will, and I think all the individual motivations that I've experienced over the last couple of years when we've been very active on that makes me very positive that things will change to the better.